Good evening, everybody. Thanks a lot for joining us for another spectacular panel of our weekly cerebrovascular and skull base University of Miami Zoomposiums. You're in for a treat today, but I guess you already knew that because you've seen the flyer and who we have today. So again, this is now session 29 of this Thursday series of seminars on December 10. I'm Jacques Morcos, professor and co-chair of neurosurgery and otolaryngology. I direct cerebrovascular and skull-based surgery. The co-directors of this series are Carolina Benjamin, my partner, assistant professor, Department of Neurosurgery. She directs our wonderful Keynes dissection lab, and Carolina specializes in brain tumor and skull-based surgery, and as well as runs our Jackson North Hospital neurosurgical service. Mike Ivan, assistant professor, director of research of our Brain Tumor Initiative. Mike specializes in brain tumor, skull base, and epilepsy surgery, as well as our two endovascular, open vascular partners, Bobby Stark and Eric Peterson. This is our beautiful Miami, and at the bottom pictures are our two main hospitals, University of Miami Hospital and Jackson Memorial Hospital. So audience members, in case you're new to our sessions, please use the Q&A box to type in your questions at any time throughout the sessions, and I promise you we will address all of them. We do not offer CMEs. This is actually the penultimate session. We only have one more to go, December 17, and we will stop doing these on a weekly basis. We might start doing them on a monthly basis. We're just hoping that life begins to come back to normal with the COVID situation, but of course, it's going to take many more months. I've asked our speakers tonight to each speak for 20 minutes. We have 5 spectacular speakers. If need be, I might give them a little warning 2 minutes before the 20 minutes are up so that we have plenty of time for questions. This has been the series of lectures in the second half, and this is where we are today, and you will see in a minute what is coming up next week. As I said, it will be our last scheduled Zoomposium on Thursdays, as well as on Wednesday, the one that my partner Mike Ivan runs, the Brain Tumor Global Symposium. But for next week, for our grand finale, we will have a cerebrovascular session, and I've given those 4 illustrious people, Ardey, Chris Ogilvie, Howard Rina, and Basant Misra, the task of this following title: Lessons Drawn from the Most Impactful Cerebrovascular Cases in My Career. So that is bound to be very interesting and perhaps very original, and actually they look forward to sharing their experience with that. So if you're interested in vascular, please join us for our last session next week. Join us also if you're interested in pediatrics with my partners who do the Monday evening pediatric neurosurgical Zoomposium. Toba Niazi and Heather McRae are co-directors, along with John Ragib and Shelley Wang, all from here, from Miami. Thank you for the 29th time to our spectacular team, Ingrid Menendez, Roberto Soazo, Cristina, and particularly Ignacio Escalona, who's running this webinar. This is a link for our department. You can see my email, you can see our departmental email, you can see my Twitter, departmental Instagram, and departmental Twitter. If you have any interest, by the way, in watching, if you've missed previous sessions, the link at the top in the yellow box will take you there. You can watch either the Thursday or the Wednesday symposium. They're all very nicely stored in our YouTube channel. So on to tonight's panelists. It is really my immense pleasure to introduce them. Of course, each one of them deserves at least a 10-minute introduction, but I certainly don't have the time tonight because we'd rather listen to them than to me. Let me start with Ed Laws, who you will agree with me, in 5 decades, his head has not changed. His smile is absolutely identical to what it was. That's remarkable. And we are all lucky that that is the case for his incredible longevity and productivity. And Ed, I don't think I really need to introduce him, but of course, he's at Harvard at the Brigham and Women, directs Pituitary and Neuroendocrine Center, has served organized neurosurgery in too many ways to recount, including representing us very well at the American College of Surgeons, WFNS president, so forth. But of course, he's here tonight to tell us of his vast experience in pituitary surgery and the lessons he has learned. Carl Snyderman, not a neurosurgeon, but of course, professor of otolaryngology and neurosurgery and director of the Center for Cranial Base Surgery at UPMC in Pittsburgh, of course, a pioneer in endonasal endoscopic surgery. Carl preceded me as the president of the North American Skull Base Society. That's why I looked bad when I followed him, because he had done such a spectacular job. And thank you, Carl, for joining mostly a neurosurgical audience, but you live with them every day, and I'm sure you won't mind sharing with us the rhinological and CSF complications of endonasal endoscopy. Dan did such a marvelous job as a panelist. We got him again as a speaker now, but of course, Dan is professor of neurosurgery, John Wayne Cancer Institute. He's a founder and the CEO of the Pacific Neuroscience Institute, Santa Monica. I will indeed forgive him for having stolen my nurse practitioner a couple of decades ago and from Miami. And Dan, of course, is extremely accomplished in minimally invasive and endonasal surgery. And he will talk to us about carotid complications and endocrine complications of pituitary surgery. Georgios Zenonos, indeed, he is a Greek, as his name implies, was my fellow in Miami 2 years ago and came from Pittsburgh, and they recognized his greatness and got him back to join the group in Pittsburgh. Where he's now assistant professor in neurosurgery, associate director of Center for Cranial Base Surgery in Pittsburgh. I've trained about 23 or 24 fellows. George is certainly near the top of this august group of trainees I've had, and I've been very privileged to have perhaps something to do with any of his training. So George, thanks for joining us. Last but not least, Andrew Little, professor of neurosurgery, director of pituitary skull base program at the BNI. Andrew has done phenomenal work. I believe, is the busiest endoscopic endonasal surgeon in the Southwest, if I'm not mistaken. And Andrew has published extensively on particularly safety and quality insurance in complications in endonasal, and he's going to talk to us about that today. So you see the incredible lineup. Here are the 5 speakers with the titles of their presentations, and I think I've spoken enough. So now I'm going to shut up, and I'm going to invite Ed to share his screen, unmute his microphone, and start his presentation. Thank you, Ed.
Oh, thank you, Jacques. And it's just such a pleasure to be here with so many friends and obvious experts in the field. So I can vouch for some experience in that I started in 1967 with my first transsphenoidal operation that was stimulated by meeting Norman Dott and Gerard Guillot. Jacques asked me to talk a little bit about staying out of trouble, and I'm just going to go through lessons that have been learned over this very long period of time in more than 6,000 cases. So number 1, do not stray from the midline. You need to know where the midline is because of the carotid arteries, obviously, and the cranial nerves. the orientation is really, really important. And you have to be able to go through the cribiform for intracranial lesions, and you have to be able to go through the clivus for chordomas. Bleeding and its control are unique in this area and can be a big problem. And CSF leaks is an all too frequent complication that can cause many difficulties. And even us neurosurgeons, we sometimes have nasal and sinus problems. So you have to have, one of the major things in avoiding trouble is understanding the hormonal issues: thyroid, DI, SIDH, hyponatremia, electrolyte imbalance, and then the other problem of DVTs and their prevention. These are all things that we have to stick with and believe in. And one of the most important things for us who do a lot of pituitary surgery is to work with an endocrinologist. And here you see me in my youth with my devoted endocrine colleague, Mary Lee Vance. So here is Georgie Murasan, who's 7'7" tall and was a basketball player in Washington when I was there. And we operated on him, took care of his acromegaly, and also I operated on his spine with a chisel because he was getting S1 weakness and couldn't play out his pension. Anyhow, we fixed that too, and he's a wonderful guy. Now, remember that progressive visual loss is truly an emergency. We never know how long it's lasted. We never know how quickly we have to operate in order to get the vision back. So here's a case of a prolactin adenoma, and you can see the terrible issue with the vision in this particular patient that was completely relieved by removing the tumor. Now, one thing happens with that can cause major problems, and that is patients who are hypothyroid. And if you give them the thyroid too quickly, they may also be hypocortisol, and then you ramp up their metabolism and they can get an adrenal crisis. So if you have to give thyroid to the patients to get them ready for surgery, make sure you check the cortisol and protect that. We no longer pack the oropharynx and the nasal nostrils. Most of the time now, we don't really think it's necessary at all. We rarely pack the nose. We almost never use a Foley catheter for a routine case, and we do not use the ICU unless we're anticipating some major problems with vision or bleeding. We don't use routine spinal drainage, as some people have done in the past. And we don't use it post-operatively either. Even if we have a CSF leak, we just go back in, as I'll show you, and repair it. Now, here's the thing I'm most fanatic about, and that's the initial positioning of the patient. And it's really key. The bridge of the nose is parallel to the floor. The head is parallel to the walls of the room, so that the midline of ambient space is the midline of the patient's head. So we fix the head so it's such that it's up against the left shoulder, and we can stand comfortably with the table tilted to the side. We angulate that for surgeon comfort, and most important is elevating the thorax about 25 degrees in most patients. And I know that the ENT people do it flat, and I don't understand why, because when we put that 25 degrees in, we can move the table, we can raise the head if there's venous bleeding, we can lower it if we need to have a different trajectory, and it gives us great versatility. And don't forget, these tables cost as much as a Mercedes, and to use them just flat seems to be irrelevant to me, irreverent to me. So we need to identify, preserve, and respect the midline structures. The vomer, importantly, is our midline signal as we're going through the exposure, and the same is with the sphenoid rostrum. So we must be very familiar with the anatomy, and this is a view from Paolo Capabianca, who was my hero in teaching me about endoscopic surgery. And you can see what the endoscope offers that was so much superior to what we did with the operating microscope. And so we also confirm these landmarks now that we can see them so clearly: the sellar floor, the carotid protuberance, the optico-carotid recess, the planum sphenoidale, and the clivus. So we have this wonderful area of exposure to treat all kinds of lesions of the anterior skull base. And it's revolutionized what we do. We still use imaging control liberally because I'm teaching residents all the time, and it helps them understand where they are as they're navigating their way the first times through these anatomic features. Once in a while, you'll see what might be a vascular lesion. And we had one, this one, it was called a pituitary adenoma by the radiologist. Well, it's very important that Dan Kelly's innovation of using the microvascular Doppler has been a godsend in not only in steering us away from vascular structures that we shouldn't operate on with a sharp object, but also in finding the carotids wherever we go, and it's really helpful. In opening the dura, I remind everybody the dura has 2 layers, just like everywhere else in the head. And between those 2 layers are vascular complexes, venous complexes, and you have to be prepared for them. And we have to open through both layers when we open the sella. Sometimes we'll aspirate if we're worried about a vascular lesion or a cyst. If the sella is large, you can go after very large intracellular lesions with supracellular extension. I know you all know that, but you can get quite far, but the exposure at the face of the sella has to be very broad and very excellent. And here's what it looks like. It goes from one cavernous sinus to the other, exposing the dura, the superior intercavernous sinus, and the tuberculum sellae here. And you can see it in real life, but we demand this sort of exposure for our operations. Now, DI is a really bad problem, and you can avoid it if you don't mangle the posterior pituitary. It looks to me like ricotta cheese most of the time, and if you stay out of it and don't cut anything and don't pull on the stalk, you can preserve the neurons in the hypothalamus, which will then find new pathways to provide the SIADH. So damaging the stalk is a very bad thing, and it produces karyorrhexis in the nuclei of these important structures. Now, just yesterday, we had a big supracellular extension, and I said, "Give me some Valsalva to drive it down." And then I sent my intrepid assistant down. I said, "Get down there and press on both jugular veins." He gets underneath the table, puts his hands on both jugular veins, and that tumor turns inside out. So we don't use a lumbar catheter anymore. And Ivan Chirek taught me this trick, and it has worked very well for us. I believe from my days as a general surgeon that dead space is nature's horror. And so we usually fill the empty sella with gel foam or with fat. Here's the fat, which I put a little cotton fibers in it and a little Avitine on it. And we put it in the sella for hemostasis and for obliterating dead space and keep it in place with a little piece of bone or porax. Now, in acromegaly, you have to remember that the bone is thicker and the blood vessels are bigger and the carotids are tortuous and atherosclerotic. The distances for your surgery are greater, and anesthesia and intubation can be very problematic. This is Harvey Cushing's first acromegalic patient from 1909, sent there from Mayo, a farmer who had changed like this over the course of 20 years or so. Anyhow, he did well. Most of our acromegalics do well, but when they respond to surgery and with the growth hormone falls, they'll look as if they have DI because they've had so much interstitial fluid. Look at this hand compared to a normal one. That interstitial fluid spills out if you're successful with your surgery, and you can be fooled into thinking it may be diabetes mellitus. Now, with prolactinode adenomas, I still make sure every patient knows that dopamine agonists have been the traditional initial management process. And so I tell them to try this drug, which is so effective in most people. And if they're non-responders, they'll come back. And if they're responders, they think you're a hero because you spared them the operation. But I recently have published a couple of things on how the results with surgery for even small microadenomas are actually better than we had fashioned in the past now because of all of the improvements we have. And we do see more surgical cases now than we did before. Cushing's is the hardest case that we have, hard to diagnose, and you have to be absolutely certain that this patient has the biochemical evidence of Cushing's disease. Otherwise, you're going to have a terribly unhappy patient who does poorly. And it's important to remember that petrosal sinus sampling is a good thing, but not pure gold. It doesn't make the diagnosis of Cushing's. You have to know that the patient has Cushing's before you try for lateralization with the petrosal sinus sampling, which costs more in the operation sometimes. Now, patients with Cushing's disease don't need preoperative or intraoperative steroids. They have enough. And so we give them no steroids and follow them every 6 hours during the first few days, hoping that they'll crash. And if they don't crash, it's very unlikely that they'll not have a lasting remission. And crashing means they become Addisonian, they get sick to their stomach, and they get a headache, and they feel lousy and weak. And then that's all they need is cortisol. We do have some complications with Cushing's that are unusual for these pituitary tumors. And Rudolf Fallbush taught me that the patients with Cushing's are hypercoagulable. And sure enough, that's the truth. And we give them 81 milligrams of aspirin the first day after surgery and for the next 2 weeks. And we've had very few DVTs. And one thing that's important especially for new residents, is you see a big macroadenoma like this, you know that it's invasive. It's pushed through everywhere. And to do a hugely radical removal, trying to take every last scrap from around the carotid, is really foolish, because they'll come back and they are the best patients for whom we recommend adjunctive radiation. But we do this very, very, very rarely these days because the surgery has been so good and so effective. We don't use nasal packing, but if we do, you need to put them on antibiotics, otherwise they get toxic shock syndrome. And if you have a patient that's getting into trouble, the most important sign they have as you examine them religiously after surgery is loss of vision. And they go right back to the imaging and to the OR. And here in a patient with postoperative CSF leaks, we don't mess around with lumbar drainage or catheters. We go right back to the OR and do the repair properly, and that works almost all the time. Vascular complications can occur at any time. Some of your commentators will be experts in that area. I've only had a few, and every one has been a nightmare. So remember that they can occur, and that's why we have to be so careful. The most common complication is delayed hyponatremia, and Dan was also involved with this, and when he was working with me, and we discovered that about 10% of patients with pituitary operations developed hyponatremia and had to come back in the hospital. It was the most frequent reason for readmission to the hospital. And we sorted that out now and have a protocol to give the patients restriction of fluid intake for the first week, and we check them. And since we've instituted that program, we've had no readmissions for hyponatremia. This is what happens, though, if you correct it too quickly. If you put them in the hospital and try to correct them very quickly, this is central pontine myelinolysis, which is a horrible problem, irreversible in most cases, and fatal in most cases. So we have had only one case of this in an elderly lady with Cushing's who went to a rural hospital, and they tried to correct her too quickly, and she died. Other things that happen with cortisol repletion have to do with patients who don't absorb the tablets well. And so if you're really worried about patients being hypocortisol, make sure you give the cortisone parenterally and don't trust the tablets. I had a patient dye an x-ray getting a flat plate of the abdomen because she wasn't feeling well and she had not been taking her hydrocortisone. And when patients are discharged and call back and say they feel horrible, it's usually cortisol deficiency or low sodium, and just send them to the ER for sodium and cortisol and stat and get it fixed, and most of them recover well. I tell all of our neurosurgical students that you have to have a friendly and competent ENT colleague. I've had some of the best that have ever surfaced, but you need them. They help you. They tell you things you don't know about the approach and about the closure, about the complications within the nasal cavity, and how to deal with postoperative epistaxis or complex anatomy. So they're pure gold, and we cherish them. Now, radiosurgery, I think, is good for some of the pituitary patients. And I like the Gamma knife better than anything. I think Jason Sheehan has been my colleague to do this, and you can get a very precise field of radiation that spares the optic visual pathways and sometimes preserves the normal pituitary. But the most common complication of the radiation, of course, is post-op hypopituitarism. We follow all of our patients religiously. We look at their scans until we're sure they're not coming back. And we see late recurrences all the time, particularly in Cushing's. Even after 20 years, they can come back. And so compulsive and continuous follow-up is really necessary. And you should know that there are 4 common subtypes, not so common subtypes, uncommon subtypes that are almost always invasive and difficult to handle. And that's the silent ACTH tumors, the acidophil stem cells, the plurihormonal tumors that involve more than 1 or 2 of the domains of hormonal synthesis, and finally the ACTH tumors that evolve in Nelson syndrome after adrenalectomy. So these are bad actors, and you have to watch them really close. So here's where Harvey Cushing started in 1913 at the Brigham Hospital. Our offices used to be up here. They moved us now for the administration to move in there, and we have a new building. But anyhow, it's been a pleasure all my life working with pituitary surgery, and particularly ending up here where Cushing worked. I hope some of these comments have been helpful to you, and they're the kinds of things that I treat my students, and I'm so happy to be able to be here with you modern experts and to hear what you're going to say. Thank you very much.
Thank you so much, Ed, for this lifelong distillation of very, golden nuggets here for the young people who are not too familiar with pituitary surgery. I'm sure they took every slide you've put there to heart. And do any of our panelists want to have a question for Dr. Laws at the moment? We will have a discussion phase after all speakers, but anybody has a burning question or a comment to make?
If some people may not like what I do, so they can voice their objections.
Well, I think Ed just distilled, a career of learning these things over and over, and all of those things he said. I mean, every single nugget, like you said, Jacques, are just so critically important, from the acute management to surgery to the long-term management. And these are, fortunately, these are benign tumors, and they need to be followed a long time. And we're still learning, that's for sure, Ed.
Yeah. Ed, maybe a question. You talk about the importance of positioning. I completely agree with you that raising the head, makes such a huge difference with the venous issues. But
we had it happen this week in our hospital. They weren't able to raise the head of a patient who was dying from venous blood pouring out of the cavernous sinus.
Yeah, it's such a simple maneuver. I agree. Okay, well, let me invite, hold on, I see a question from the audience. Okay, Dr. Laws, this is from Dr. Adham Khalafallah. What is your personal post-operative protocol to decrease CSF leak?
To decrease CSF leak? Well,
Yes, I guess post-op.
careful monitoring of the patient. So let me tell you what I do. If I think we've had an intraoperative leak, I will get a CT scan without contrast and look for air bubbles. And that will give you the best indication that a patient may have a CSF leak. So that's number one. Number two, of course, we lean them forward, we lean them down, we see if they're dripping out their nose. And we don't usually anymore try to get transferrin or biochemical studies to show whether it's CSF. You can't really tell. But we take them back, and if we think they're leaking, I just take them right back to the OR. The pathway's there. It takes half an hour, and you can seal it up again.
Okay, thank you, Ed. We'll talk at the end again. Carl, let's get you on board. If you could unmute and load your slides. Thank you.
Thank you, Jacques. Can you see my desktop now, my presentation?
Yes, indeed.
All right. Well, thank you again. It's a pleasure to be speaking to everyone online tonight. And I have the pleasure of speaking about the reconstructive and rhinological complications of endonasal skull-base surgery. I'm speaking to you from Pittsburgh, a city known for many things, which I won't go into right now. I'm a consultant for a company. I will not be talking about their product tonight. And for all of our international colleagues, no, I did not vote for Trump. I want to make that perfectly clear. So when we look at complications and the morbidities that result from them, I like to divide them into sort of three buckets: the almost never events like vascular injuries, and the common events include CSF leaks and the sinonasal morbidity, and unknown morbidity. What are we doing to the brain? So I'm going to focus on the common events in my presentation. This is something, or looking at CSF leaks, this is something that we track on a regular basis to see how we are doing and to constantly improve our results. And here you can see for the last 5 to 6 years how we've been doing as a percentage of post-op leaks for intraoperative leaks and total cases. And this year's data is pretty much in line with what we've been doing in the past. What are the risk factors for getting a post-operative leak? There are some preoperative risk factors. The morbid obesity of patients, their BMI has been shown to correlate. And then we also think patients with revision surgery are at increased risk, especially if they've had surgery that compromises your reconstruction when you need a vascularized flap. And recent data from our institution also shows that nutritional deficiencies preoperatively increase your risk of a postoperative CSF leak. Operative factors where there is evidence for an impact include the site of the defect, your own surgical experience in repairing these defects, the type of reconstructive technique, especially the use of vascularized tissue for reconstruction, and selective use of lumbar drainage. And I'll talk more about that in a minute. And this really summarizes how we approach reconstruction. For most large defects, the septal mucosal flap is going to be our primary choice. If that's not available, we will use a lateral nasal wall flap or extracranial pericranial flap, depending upon the situation. And clival defects are particularly challenging, and we advocate a 4-layer reconstruction of those defects. And so the leak rate should be about 5 to 10% using this approach to reconstruction. So just to go into greater detail here, for a large anterior cranial based defect, we will do an inlay collagen graft, an onlay, but preferentially epidural tucked fasciolata graft, and then a vascularized nasal septal flap. For an anterocranial based defect, especially patients with sinonasal malignancy, the nasal septal flap is often not available. And so our backup plan, or our preferred plan in some of these tumors, is actually an extracranial pericranial flap. So this is brought in through a small window. We do a bicoronal scalp incision, expose the bone to the nasion, create a window below the plane of the skull base. So we're coming in at the bottom of the frontal sinus, and then raise a generous pericranial flap and pass that flap through the window without any cosmetic or functional deficit for the patients. And so here's that reconstruction, the inlay collagen graft between the brain and the dura, an onlay fasciolata graft tucked between the dura and the bone, and finally the extracranial pericranial flap, which covers the entire graft. For clival defects, we do a 4-layer reconstruction, inlay collagen graft, onlay fasciolata, a small fat graft to fill in this clival defect, and then a vascularized flap, either a nasoseptal flap or a lateral nasal wall flap. And here's that reconstruction. Here's our clival defect below the sella, an inlay collagen graft between the brain and the bone and the dura, an onlay fasciolata graft, and this should be very generous, so it covers the sides of this defect as well as the deep surface. A small fat graft, just enough to fill this in, and this is essential to prevent pontine herniation in some patients. And then a vascularized flap. Especially important to cover all of the fat and the fasciolata. Make sure I'm not missing a slide. Okay, prevention of postoperative leak. Lumbar spinal drain is used selectively in patients in addition to these other considerations. We did the only prospective randomized trial in endonasal skull base surgery looking at the value of postoperative lumbar drainage, and we showed there was a clear benefit for large defects of the anterior and posterior fossa. For sellar or suprasellar defects, there really was no benefit in using a lumbar drain. And so that has become our protocol for the management of these patients. If we should get a leak, we treat it like an emergency. We take that patient back for repair within 24 hours. And most of the time it's just readjusting the primary repair, and maybe adding a little additional tissue to bolster the repair, and then placing a lumbar spinal drain. And here's an example of a patient where we have several problems that resulted in a postoperative leak. You can see that our flap has shifted. It's no longer in the place that we put it. And so it's overlapping mucosa. It's not in an optimal position for the defect. We've also left some mucosa in areas that may interfere with adherence of the flap. And we can see that there's a small perforation of the flap that we didn't recognize at the time of surgery. This may have been from a septal spur or just injury from instrumentation. So we take the flap down, get rid of the residual mucosa. And so to re-prep the edges, making sure we have a good base without any mucosa or bone chips, and then reapply the flap. And so, 95% of the time, this is going to take care of the problem. Sometimes the flap is not adequate and you need additional tissue, in which case we can use non-vascularized tissue or vascularized tissue. If we use a vascularized secondary flap, most often a lateral nasal wall flap or a pericranial scalp flap. It's always instructive to analyze your failures to see what went wrong. What can you do differently the next time? And so we always do a root cause analysis, looking at all the possible factors that contribute to a postoperative leak or a vascular injury or any other complication. And so for a CSF leak, you can see there are patient factors, the material factors, the technique, as well as perioperative care. And I think we've pretty much discovered every possible way to cause a postoperative CSF leak. Some cautionary notes: be very careful about blind nasal instrumentation in your patients postoperatively. Here are the only two disasters we've had over the years where people passed nasogastric feeding tubes without looking, and it can go intracranially and track through the brain. And so we have signage that warns people not to do this. And the only people who are allowed to pass tubes through the nose are members of the skull base team, and this should be done under direct visualization. So here's a misplaced nasogastric tube that actually went between the layers of our reconstruction. And so we were fortunate we were able to remove this tube without undoing the entire reconstruction, just pulled out the tube and replaced the vascularized flap. But be very cautious about that. What about the risk of infection in these patients? Overall, the risk of infection is low, but the number one risk factor for meningitis is a post-op CSF leak. If you can prevent leaks, you're going to prevent infections. And let's move on to talk a little bit about sinonasal morbidity. You know, there are a lot of problems that we create because of the corridor that we use and the types of reconstruction. And all of these factors really have an impact on the quality of life of patients. Now, sometimes the tumor has created the morbidity for us. You know, taking out this tumor doesn't create a defect any bigger than the dimensions of the tumor. And so any morbidity that you have here really is a function of that tumor. In contrast, if we're using an endonasal approach for this large olfactory groove meningioma or schwannoma, the morbidity that we have in the nose is all a consequence of that corridor. So in different situations, we are contributing to morbidity. There has been an abundance of quality of life studies in these patients. And overall, the effects on quality of life are very minimal. It's only in the area of specific symptoms that we see problems. And these are the most common symptoms that people complain of. You know, nasal obstruction, loss of olfactory function, discharge, crusting, difficulty sleeping at night. But these can be very significant for patients. The use of the widespread adoption of the nasal septal flap for reconstruction has introduced additional complications that we need to be aware of. We've described the rare complication of nasal septal flap necrosis, in which all or part of the flap can die. And what's interesting is that these patients do not present with the CSF leak. They present with a localized infection that can result in meningitis. You very well may notice a foul smell from the nasopharynx, from the dead flap. And with postoperative imaging, you'll see a lack of vascularity of the flap, as noted here. Risk factors for development of a necrotic flap include the use of a fat graft as part of the reconstruction, and prior endonasal surgery is a strong risk factor as well. These patients need to be treated for infection. An MRI scan can help confirm that there's a non-vascularized flap. And then these patients require debridement of the dead tissue and then secondary reconstruction using an alternate vascularized tissue. We can prevent these flap necrosis by understanding the vascularity of our flap, especially in revision cases where we have a very narrow pedicle. ICG fluoroscopy is helpful in delineating the vessels. We can actually see the vascularized pedicle here, and we can confirm that with the use of intraoperative Doppler. And here you see an example of a post-op MR showing a well-vascularized flap. Studies using MRI appearance and ICG fluoroscopy show that when the flap pedicle and the body do not light up and the MRI shows no uptake, there's a high risk of flap necrosis. In the absence of those problems, flap survivability is very good. Another complication that we've noticed in a small percentage of patients in our early series, about 6% of patients, is a saddle nose deformity and loss of cartilaginous support for the nasal dorsum. And the overwhelming risk factor for this is the use of a nasal septal flap. We don't entirely understand the mechanism for why this occurs. It occurs even when there's plenty of cartilage support for the nose, but it may have to do with some loss, resorption of cartilage, or disruption of ligamentous support for the nose. In some patients, this requires a plastic reconstructive procedure. We have noticed, however, since we started using a reverse septal flap to cover the donor site on the septum, in all of those patients who have a nasal septal flap, that we're not seeing any cases of nasal dorsum collapse. So we think that helps prevent it. Obstructive sleep apnea is a concern in these patients postoperatively. In Pittsburgh, we have a high incidence of morbid obesity, and these patients may have packing in their nose for up to a week. And so these patients are managed in the early perioperative setting with oxygen if necessary and close monitoring. There are no good studies really looking at the risk of complications with OSA and how best to manage them. When we looked at our own patient population, there's a high rate of non-diagnosis of obstructive sleep apnea. So you really can't use that as a risk factor, but you can identify a high-risk group. Patients with a high BMI and pre-existing hypertension are much more likely to have respiratory events postoperatively, and these are patients who require more careful monitoring. You can see these patients also have a higher risk of a postoperative CSF leak due to the high CSF pressures that they generate. It's not entirely clear when it is safe to resume CPAP. Surveys of skull-based centers show that most centers will resume it at 1 to 2 weeks postoperatively, and that has been our protocol as well. Extracranial pericranial flaps may result in obstruction of the frontal sinus postoperatively. Usually we can maintain a drainage pathway on one side, but oftentimes there is obstruction. If that happens, most of the time we just observe it and the patients are asymptomatic and there's no progression of the obstruction, there's no mucocele expansion. However, in patients who are symptomatic or have some expansion of a mucocele, we could do an endoscopic drainage months after the surgery is complete. And then a final consideration is, how are we altering the microbiome of the sinuses with endonasal surgery? That's something that has not been studied well. We know that there's an increased colonization with Staph aureus postoperatively, and a certain percentage of our patients will develop chronic rhinosinusitis, and this can be quite problematic in a small percentage of patients with chronic crusting, recurrent infections, and this can be treated most of the time with topical antibiotics and steroid rinses, but some patients may require endoscopic surgery to deal with the chronic infection. Olfaction is also a concern. Extensive surgery within the nasal cavity can clearly affect postoperative olfaction and taste, and this can be a significant quality of life issue for patients. With the design of nasal septal flaps, it's very important to preserve the area of olfaction, and nasal septal flaps do not have to result in a loss of olfactory function. So my final piece of advice is you can't prevent complications necessarily and all of the time, but there are a lot of things you can do to minimize the risk of these complications. Thank you for the opportunity to speak with you tonight, and I look forward to the question and answer period.
Thanks, Carl, very much. Very nice summary of most of those things that can go wrong from the rhinological perspective. Any comments from panelists? I don't see an audience question for now. I'm sure they'll pop up later. Here we go. Okay, that's a good question, actually, from Andrew. In case of a Radke's cleft cyst, where the goal is fenestration, how do we handle a weeping CSF leak from the cyst? Carl, why don't you take that one?
So certainly our goal with the Rathke's cyst is to drain the cyst without getting a leak. And so we're very careful not to instrument the arachnoid layer or the diaphragma and avoid that leak. If we do get a leak, weeping is a leak. So then you've got to put a graft on it. And oftentimes in a low flow situation like that, we will simply use a free mucosal graft from the resected middle turbinate or the nasal floor. If it's a higher flow leak, then we'll use a nasal septal flap. And certainly that increases the risk of recurrence, but you have to treat the leak.
I would, on that question.
Go ahead, Dan.
Yeah, we've been talking about this grading system for a long time, and as for a weeping, what we call grade 1 leak, we don't use nasal septal flaps for those. And I doubt, Carl, you guys use them very much for that situation either. I'm not sure, but we use mostly, we use fat. We have a very low threshold to use fat. I have Ed to thank for that. And we find it extremely useful if there is a dead space, like Ed said, the dead space issue is really important. And maybe it does increase the risk of a recurrence, but if it's really small and there's not much of a dead space, we use collagen sponge, and we put sometimes we harvested bone from the septum, and then some tissue glue, and then we decide, and the tissue glue is really just to hold the collagen in place. And then we may use a Miracell tampon. We have a pretty low threshold to do those, as well as a temporary buttress if we can't wedge something into the sella, which we often do as well. So I think it's good to have a variety of strategies, but just ones that work.
Yes. Yeah, CSF leak repairs are one of those things where most everything works if you do it right, and everybody has a different experience, and so you have to rely on your own experience.
Right.
Okay, Dan, why don't we move to you? Thanks, Carl.
Thank you.
Okay, so let's see here. Okay. Can you see my screen? I'm going to go full screen here.
Yeah, you're in navigation mode right now.
You got it?
Now
Okay.
we've got it. Thank you.
Okay, so those are two great talks. I've been asked to focus a little more on two particular types of complications, specific ones: carotid artery injuries and hypopituitarism. Of course, one is one that you know about immediately while you're in the heat of the moment, and the second one is one you might find out about later when the patient has follow-up testing. There's my disclosures coming to you from Santa Monica, California. So really, when we think about complications, I think Ed laid this out really well. You have to think about kind of from the beginning to the end, the patient selection and workup, your own experience and instrumentation. Then once you're in the surgery, there's all these things that we have to do carefully to avoid complications, including the nasal phase as it relates to anosmia, the sellar exposure being adequate. And that really gets to the idea of localizing the carotids. And then the tumor removal and gland preservation are critical steps, as we know. And then finally, the reconstruction, which Carl just mentioned, and hopefully you have a successful outcome. And we're all aware of the major complications that can occur. And as the years have gone on, I think it's remarkable how infrequent catastrophic complications are occurring now at busy places where there's relatively high volume experience. And so again, I'm going to focus on carotid artery injury here. This is from an original paper we did many years ago, how I had my first carotid artery injury just like that, and then hypopituitarism. And if you look at a bunch of series, and this slide hasn't been updated too recently, but there's some other good studies, but they all show about the same thing. This range of anterior pituitary failure is anywhere from 2 to 14%, and permanent DI is usually under 5%. Fortunately, carotid artery injury is usually 1% or less in most large series. And I think it can almost be one of these things we call a never event. I do think that the rate of ICA injury is probably underreported beyond peer-reviewed publications, because I know many of us get consulted about medical legal issues with carotid artery injuries that occur out there. So I think as a first start, anatomy is key, and studying the imaging is critical to see, where is the adenoma relative to the normal gland, and how the gland is compressed, and this is really critical knowledge. Also very important, Ed mentioned the posterior lobe, and postoperative DI is a really unfortunate complication, and you can almost always see the posterior lobe on an adenoma if you look at the T1 non-contrast enhanced images. And in an adenoma like this, where you have the gland being pushed over to the left, the posterior lobe is going to be plastered over there, and you need to be aware of that and think about it. Similarly, sometimes the gland is pushed forward and draped over the adenoma, and you may have to incise the gland. I'll talk a little bit about that. And then be aware of the unexpected. This is a patient with a cranio So when we did a CTA on the patient, we found this, well, actually we saw a flow void, what we thought was maybe a flow void in the cell, and this patient actually had a cavernous aneurysm, and so we did this through an eyebrow. Again, the anatomy is key, and you're all familiar with this anatomy, but just so important to beware of the normal course of the carotids. And then the sort of pathological invasion that can occur, and this is a beautiful paper from Juan Fernandez Miranda of the cavernous sinus compartments extending onto the nos grading system, and I think this is all really critical to pay attention to as you relates to the carotid artery. So you have to appreciate the pathological distortion. It's one thing to know the normal anatomy, but you got to know how is the carotid being distorted or enveloped by the pathology. And again, all of this anatomy, as you're looking at the sella and the posterior sphenoid, as you're opening up, thinking about where all these structures are, including the optic canals and the cavernous carotid arteries. So when you're doing the procedure, obviously a wide sphenoidotomy, the wide bony opening, we use the Doppler probe, and I think Ed mentioned the Doppler. The Doppler is really your friend and your savior of the patient, and I've learned this the hard way. We never open the dura until we've used the Doppler to really confirm where it is before we do the dural opening, and we typically do a U-shaped dural opening and then can extend it out over toward the edges as needed. You want to beware of, and that video is playing okay. You want to beware of the dehiscent carotid, and this is often the case, and you can see it as you're starting. There's just a little mucosa over this carotid. You can see it pulsating here. And why that's important, if you watch this case here, this is not my case, but someone that was nice enough to provide it for us. And you can see there's been some cautery here. And watch what happens. So that's not a good thing. That is a carotid artery injury, probably because of excessive cautery use over the dura there. And we never use cautery like that, and you should just never put never be bipolaring that sort of thing unless you know exactly where you're at. Here's another way to do the injury. This is with a debrider in the sphenoid sinus. There's many ways to get there. Like I said, this is how I did it initially, not using the Doppler. This is from our paper many years ago when we were using the speculum and got the contralateral carotid because you get more exposure. So, you know, why does it happen? Getting lost, just forgetting, not being mindful of the carotid. And you can do it with a whole variety of different instruments, blades, cauteries, the debrider, the drills, kerosins, tumor forceps. But really, again, prevention is the key, and it often occurs in the setting of not using the navigation or the Doppler. And as Ben Franklin said, an ounce of prevention is worth a pound of cure. And he also said this, that carotid artery injuries are preventable. I don't know if you knew that about Ben Franklin, but he was way ahead of his time. And so we use the Doppler in every case. I think it's a very helpful thing. This is my show with Dr. Chester Griffiths, my ENT partner. And, you know, it's live navigation. It's real-time navigation. And we know that our surgical navigation is sometimes off. And the Doppler is really, I think, that's what sets it apart here, and really allows you to make a wide dural opening and make sure you know exactly where it is, where the carotids lie before you incise the dura here. And then you can open the dura confidently and not worry that you're going to enter into a terrible event. This is showing this is a somewhat old video, but showing this invasive macroadenoma going out over into the retrogenu space here, and using the Doppler to map that out. And then I'm just going to speed this along here. just showing the initial removal of the tumor, a very soft tumor here, and removing the tumor in the central part of the cella first, and then using these hook knives after we know what the carotid is to open the dura right up to the edge of the carotid, and to allow us to get into the cavernous sinus, this component here. And with an angled endoscope, you can see that we're gently massaging the carotid here. We're in the retrogenu space, removing this this cavernous component of the tumor. Now, obviously, we may not be able to get all of this, but this is a way, with using the Doppler, you can do this safely. And obviously for other tumors, this is an invasive skull-base meningioma, where we did an endonasal transcellular and transclival debulking. And you can see this vasculature. You can see within the tumor here, this is the basilar coming up, the basilar bifurcation. And this can be very hard to know exactly where it is when your navigation is not working, or your navigation is off. So the Doppler can guide your dissection and give you very good information about when you should stop. We've also implemented something called the carotid artery injury timeout when we have a case that we think it's a little more high risk. So patients with previous surgery, prior radiation, a really invasive tumor, some fibrous tumors, and we go through a checklist with anesthesia and the team in the room, just to make sure we all know what we would do in case something really bad would happen. We actually haven't had to enact this since we implemented this, but we think it's a good protocol to follow. So what are the intraoperative essentials? So navigation, Doppler, large bore suctions, fat and muscle grafts readily available. Muslin gauze is extremely helpful in my experience for small perforating injuries. The aneurysm clip tray, obviously one that you can get down the nose. The endonasal pliers need to be nearby. Heparin drip ready. And then, of course, interventional neuroradiology should be not too far away. This is from our paper from many years ago, where we had an almost 2% rate of ICA injury in our first bunch of cases. And again, since using the Doppler, we have not had a carotid artery injury, a direct carotid artery injury. We had a branch injury, but we have not had any in the last many cases. So I think this works really well. This is a nice paper from Paul Gardner and from Carl Snyderman on their experience with carotid artery injury that they published in 2013. And you can see they had 7 injuries in over 2,000 cases. And you can see they detail how it happened here. Fortunately, most of these patients did really well, a very highly experienced skull-based team. And in talking to Paul Gardner, and Carl, you can confirm, this was in the era before you guys had really started using the Doppler, and I think that has subsequently changed. And so again, a very low rate in an extremely experienced group. This is a paper from 2016, a review, and you can see they looked at 50 ICA injuries collected throughout the literature. Most patients do well, but 5 died, 4 of them in the OR. So overall poor outcome, below 20%. But again, this is typically an avoidable event. And in this paper, interestingly, the word Doppler was nowhere to be found in the manuscript. So I think that, which is a little surprising, and I think that that's something people should be using. So anyway, know your anatomy, appreciate the pathological distortion, be skeptical of your anatomical prowess, trust but verify, and really think carotid before you cut or bite. And that is something that Ed always said to me, and it really pays off. And I think the Doppler is your friend and companion. So I'm going to move on to avoiding hypopituitarism. This is an image, obviously, of a giant adenoma, very large tumor. You can see the normal gland extremely compressed here. There's a little hemorrhage. This patient had mild pituitary gland failure, mildly low hypogonadism. And you can see the tumor came out nicely. And look at this descent of the gland here, from here to here. This patient went on to become pan-hypopit with DI. And I think in some of these cases, it's very hard to prevent simply because of this translation of where the gland was to where it is at the end of the procedure. Whether putting a big fat graft in here can prevent that or not. So in some cases, despite your best efforts, it may not help. And when we've looked at this in great detail, it's clearly size dependent, so that with giant adenomas, the risk of permanent long-term gland failure, at least one axis, is around 15%. But anything under 2 centimeters or less, it should be close to zero for most adenomas, 1 or 2% in our experience. And so it is definitely size dependent. So what are the things you can do? Well, you want to obviously identify the anterior and posterior gland on the pre-op imaging. Addressing the mass effect early in tumor removal, I think, may help. And then incising the gland or removing small portions of the gland and avoiding placing undue traction on the gland and infundibulum. And then utilize a pseudocapsular technique if possible. So again, find the posterior lobe. You can see it on virtually every case. When you're done removing the tumor, as you're removing the tumor, you'll see this hyperemia of the gland. And Ed Oldfield published on the pseudocapsular technique quite a while ago, and I think this is a helpful methodology. This is just a sort of some drawings here, a cartoon of showing a compressed gland here with a macroadenoma, and going through these steps of dissecting the tumor away from the gland here, away from the cavernous sinus, and then we do this early decompression. We usually remove the inferior pole of the tumor first. That takes more pressure off the gland superiorly and perhaps the chiasm, and then continuing with the pseudocapsular dissection. And you ensure in most cases, a complete removal, and you protect the gland. So here's just an example of a case. This is a macroadenoma here. You can see it's got this interesting extension up just under the optic nerve. But so here, very, very importantly, this dissection is showing you the interface between the gland, which is compressed over here, and the adenoma. And this tumor happens to have a pretty good pseudocapsule, so we're going around that as much as possible, getting it defined, and then coming across the sort of the belly of the tumor, or the equator of the tumor, and removing this lower pole to take the pressure off the gland that's more superiorly here. And then again, working on this pseudocapsular dissection below, because the normal gland is coming around like this and then thinning out along the floor here. I'll go through this a little bit more quickly here. And you can see now we're trying to bring the tumor down from the compressed gland superiorly. And this is getting into this area where there's tumor invasion, a little bit of tumor going up through the diaphragmacella here. But again, this progressive removal, just working the adenoma away from the gland. And as you do this, you can see the tumor becomes more pale and the gland becomes more hyperemic. And that's a very consistent finding as you devascularize the tumor and you take the pressure off the normal gland. And just gentle working with the ring curette that you can see through, and sometimes 3 hands. But basically, this is a nice technique to allow not only a complete removal, but protecting the gland. I'm going to keep going here. How are we doing on time, Jacques? We okay?
About 5 minutes, Dan.
Okay, perfect. Perfect. So this is just, again, going some of this tumor going off toward the cavernous sinus. I'm going to skip that. The point here is this technique. Here's a large macroadenoma, again, somewhat of an old video, but look at the normal gland really draped over. And as you open the dura here, you can see this very, very thin crescent of normal gland and the pseudocapsule of the tumor here. So this is the tumor. We're going to release that. We're going to relax it and make this incision here to allow the normal gland to ascend up and get out of our way so we can remove the tumor below. You can see this very clear demarcation of gland and tumor. And it's a very consistent finding. Sometimes the pseudocapsule is not very firm and you'll break right through it, but if you can utilize it, it's helpful. And again, doing this inferior debulking, we find is a good way to take the pressure off. And here's the gland up here already more hyperemic. Okay, I'm gonna keep moving here. So my partner Garni Barkadarian, we looked at this gland incision, what was the impact on gland function, and we did this in a significant portion of this cohort here, and we only had new hypopituitarism in three patients, 4% of the group who had a gland incision or gland resection. So it does seem to be quite well tolerated. And this is just an example of a patient with Cushing's with a negative MRI. And I'm going to run through this quickly, but this is the kind of exploration that has to be done sometimes in a negative MRI Cushing's patient, these multiple vertical incisions to explore the gland. And these are quite safe for the gland here. I'll just move through this here. We eventually found the adenoma way over on the far right here. You'll see we finally find the pseudocapsule of the tumor right here. We highlighted it there if you couldn't see it. But this is what was causing her Cushing's right here. And so the point is not so much on finding the tumor here, but that this sort of incision of the gland, as you can see here, almost like a loaf of bread, it's very well tolerated if you don't go too high. You can go all the way back to the posterior lobe, to the interface, and the gland will tolerate this. And anyway, here we're removing the tumor, removing some bone, cauterizing the dura, going up against the wall of the cavernous sinus to make sure we get this patient in remission, which she did. And then finally, just on craniopharyngiomas and tuberculomangiomas. So this, if you have a patient with a cranio that has intact gland function, as this man did, and you can see the infundibulum, you should be able to preserve gland function in many of these patients. And as you'll see in this patient, as we open the dura here, you can see the superior apophyseal dragged over from the left, going up to the infundibulum here. We're draining this cyst, and you'll get a very nice view of the infundibulum here. Right here, there's the infundibulum. And it's got tumor all over it, as you would expect from a craniopharyngioma. But this can be dissected away in a gland and stalk sparing way. And so we're just carefully taking that away from the infundibulum there, and obviously trying to keep that superior apophyseal intact. You can see the chiasm there. And so we did probably leave a little bit on the undersurface of the chiasm here. This patient kept normal gland function, and for years he did have a small recurrence years later and had stereotactic radiotherapy. But you can see here, here's his pituitary gland with the nasal septal flap. This is him years later. Again, you can see an intact infundibulum and gland. And he's gone on to have SRT and is doing well. Finally, this case, this is a really calcified tuberculomeningioma, and I'll just bring your attention to this right here. Here's the infundibulum. This is very calcified, but he had bilateral optic canal invasion, so we did do this from below with the idea to decompress both optic canals. But this is really a calcified rock. And but I want to just show you where the infundibulum comes in here. We make a little incision in the gland there to relax the gland, and now you'll start to see the infundibulum toward the back of the tumor here. And this is really key. And with a calcified tumor like this, you have to really be careful because of all the transmission. So there's the infundibulum right there. And you have to be very careful that you're not transmitting too much force on that to injure the stalk and the connection. So this is one we had to use the Kuza on. Having a little, there we go. Okay, so I'm just going to go a little further. You can really see nice views of the stalk there. And eventually we're able to get the entire tumor out. But there's a nice view of the infundibulum. And I'll just show you the, hang on, the zoom bar is getting in my way. And I'll show you the final view here. With the infundibulum intact. Oh. Right there. So very possible to do this and should be done in most tuberculum meningiomas. And this is his scan here. You can see the infundibulum there on his immediate post-op MRI. In summary, for adenomas, useful to address mass effect on the gland by early tumor debulking, incising or partially excising attenuated gland to expand the view is a good way to preserve the healthy gland. You should really avoid wandering into the posterior lobe. And as Ed said, it looks like cheese, cottage cheese or ricotta cheese. For craniopharyngiomas, if they have intact function, gland and stalk preservation is often possible. And it should be possible in the vast majority of patients with tuberculum meningiomas. Thank you.
Thanks a lot, Dan. Excellent, excellent lecture covering those two important topics. Of course, you know, the carotid injuries are very dramatic, and I mean, it's obviously usually quite easy to stop the bleeding by packing, but indeed you can stroke the patient and so forth. And you know, all the points made are absolutely essential that you made. Any other comments from the panelists? The audience doesn't have a question at the moment. I'm sure they'll have some more later.
Dr. Kelly, is George Zenonos. Beautiful talk. And thank you so much for introducing the Doppler so all the rest of us can do surgery in a safer manner. What are your strategies? Usually, if you don't need to expose a carotid, obviously we don't need to, but when you do need to expose a carotid, are there a particular sequence? Is there a particular sequence of events that you use to do that? Or are there any pointers that you have to share?
You mean when you're exposing the carotid?
Yes.
Well, I think, you know, just first of all, knowing where it is and sort of sneaking up on it, you know, going to the easy part of the cell and then working your way out and using the Doppler frequently. I think, you know, I think Carl and his group have showed, Danny and Rick Corral, this, you know, the anatomy around the carotid with the medial OCRs. You know, those kind of anatomical structures are very critical to understand. And I think using a combination, we use a combination of the drill and Keras and Rangeurs. And I think you just have to work, you know, really carefully and cautiously. And it's something that probably if you haven't done it much, you should spend time in the lab doing it. But I think the main thing is just to go slow and cautiously and you know, use your navigation and Doppler frequently to make sure you don't do something that you will regret.
Okay, George, your turn. You're muted.
Can you see my screen?
Yes.
Is this the first slide? You're seeing the first
I'm sorry?
slide? You're seeing the first slide of the presentation?
Yes.
All right, excellent. Well,
But George, we also see reminders, your Outlook reminders on the top right.
all right, give me one second. Better now?
Yes.
All right, excellent. Well, I couldn't be more humbled to be among such a superstar panel. I really don't deserve to be here, and I thank Dr. Morcos for having me be here. Dr. Morcos asked me to speak a little bit about in how many ways can and expanded endonasal approaches go wrong. And certainly even after a year and a half of being in practice, I've managed to call some unique ones, which I'll try and share. Well, I'm lucky enough to be surrounded by partners that were my mentors in learning skull-based surgery, and I've learned everything from them. Most of us are old-fashioned guys, except one of us, which is quite progressive. I can rock a pair of those with no questions asked, actually, by anyone. I also want to thank Dr. Morcos. I tell him that often, try find ways to call him and touch base with him one way or another. I've learned so much from him inside and outside the OR. And I've definitely learned how to have a good time outside the OR. It really puts everyone to shame for that. So briefly, expanded endonasal approaches essentially refer to endoscopic skull-based surgery, which goes a little bit beyond what most of us know as pituitary surgery. And now we have to deal essentially with exposures that extend from the cranial plate down to the odontoid and laterally as far as the cranial nerves will allow us in the vasculature. And therefore the stakes are high. The major vasculature as well as the cranial nerves are additional points of injury that we obviously have to be cognizant and try to avoid injuring. And the complexity of cases as skull-based cases obviously increases exponentially, and every little step has to be perfect. Even things that seem to be okay in the operating room, if you leave them alone, they will come to bite you. And many times we know that the surgery is not done until several months after surgery actually is not done in the PACU, or it's not done when the patient leaves the hospital. There have been several advances in endoscopic endonasal approaches, and we've managed to kind of compartmentalize things into modules, knowing each module what kind of vascular anatomy and cranial nerves is associated with, and know how to deal with them. The first, I guess, expansion is knowing how to deal with the cavernous sinus. In pituitary surgery, that has been a limitation, and for a long time, it has been known as no man's land. But we also know that limited exposures led to incomplete resections, need for craniotomy or radiation. And with application of skull-based notions and skull-based anatomy, we can essentially make pituitary surgery as well more of a skull-based procedure, knowing how to compartmentalize the cavernous sinus, which was popularized by my mentor and friend, Dr. Fernandez Miranda. Also finding ways to know how to stop cavernous sinus bleeding with modern hemostatic agents, and also electrophysiology. Understanding the anatomy of the dural layers, and especially the medial wall of the cavernous sinus, which now has been understood to be the site of origin for many of the recurrences, when many of this, especially the functional adenomas, tend to recur from that area. And this is a case of mine. This actually had been operated on approximately 5 years before I met this lady that had Cushing's disease. She had recurrence of symptoms and endocrinologic evidence of recurrence. But the tumor was growing actually in the medial wall of the cavernous sinus. So here we're using the eggshelling technique to expose the anterior inferior wall of the cavernous sinus. We will be using the Doppler that Dan Kelly donated to us to find the carotid artery, and then we're trying to use the extra capsule technique that was shown to us by many of the giants, such as Dr. Laws, on how to go around and find the plane with the pituitary gland. We're heading more medially towards the cavernous sinus. Eventually, we have to open the cavernous sinus here. And I'm opening the cavernous sinus and packing it. Here, we're injecting gel foam into the cavernous sinus. But we have to go on both sides of the cavernous sinus. This is the safest area to open the cavernous sinus in this anterior inferior border. And we really have to open it completely in order to be able to pack it so as to be able to open it. And the two layers, as Dr. Laws was explaining earlier, there are two layers of dura, especially down lower. The periosteal layer of the dura does not fuse with the adventitia up to the proximal dural ring and down to the foramen lacerum, so we can put them apart. And now we know from the modern anatomy, the pituitary ligaments is the inferior paracellular ligament that comes into view, and we're using the cartouche to make sure that we're not inadvertently going up to 6, although this is far. The strongest ligament is the carotid-clinoidal ligament that we're disconnecting here all the way to the back of the cavernous sinus. We're in the posterior compartment of the cavernous sinus here. We have to watch for current nerve 6. And again, I'm packing the cavernous sinus posteriorly with gel foam. Now we'll make our superior cuts, and again, using that extra capsule technique to completely liberate this involved cavernous sinus and floor of the sella. This is the inferior hypophyseal artery that I'm coagulating and dividing here. And I'm not going to belabor this, but up to the end, I was still having a little bit more bleeding from the posterior wall of the cavernous sinus. I inject a little bit more gel foam in the posterior compartment of the cavernous. This is a redo case. That's the reason we have used an nasoseptal flap, because in case we needed it, we needed to be able to know that it was there. The patient did well initially. She actually crashed. On the third day, she started complaining of double vision. And on examination, she developed a partial current nerve 6 palsy. This was in all likelihood because of the packing of the cavernous sinus. When I had seen her 2 weeks after, her diplopia had largely resolved. And we know from the data that was produced that this happens approximately 10% of the time that people do have transient current nerve deficits. And actually 2 people had blood clots that needed to be evacuated. This is another case that I operated on recently. Is a patient with a tuberculum implantum meningioma, had very severe loss of vision on the left side with bitemporal hemanopsia and essentially encasement of both optic nerves with extension of the tumor in the left optic canal. So because of the extension in the optic canal, I chose to do this case endonasally. Here is us exposing the optic canals and drilling the top of the optic canal on either side using the 2mm diamond burr with the irrigating bit. It's actually very helpful to use and drill in this very tight corridor. You can get up to the mid-level of the optic canal and very proximal to the clinoid, but when the clinoid is small, it's very hard to get much further than that. Eventually, making into the tumor. Tumor was somewhat fibrous, internal debulking, extracapsular dissection as usual. I'm going to speed it up a little bit. It's very important, as Dr. Kelly was mentioning, to make sure that you find and preserve the superior hypophyseal arteries, which will come into view, and using with angle endoscopes, you're working underneath and preserving the macrovasculature of the optic nerves. Here are the superior hypophyseal arteries that are identified and preserved, and eventually opening up the medial optic canals to remove the tumor from there. These are extending laterally to the optic nerves above the optic nerves in the area of the anteroclinoid. but not directly on it. One of note here is that we had used a decent amount of gel foam as well as meter cell packing. And the patient woke up at his neurobaseline. He had a CT scan in the beginning that showed no issues. But on morning rounds in the morning, we noticed that on the left eye, he had decreased vision, and he had very poor vision in that eye, so it was a little bit hard for him to appreciate. But we got an emergent MRI, and it was evident that the packing had expanded to the point that was compressing the left optic nerve. So we took him emergently back to the operating room and repositioned and removed all the gel foam that had expanded. When I saw him, actually, I just saw him like last Tuesday, the vision in his right eye had improved, and he had improved as he had left the hospital. But on the left eye, it was more or less the same as pre-op. Pituitary transposition is another skull-based module that allows us to reach the superior clivus and the midbrain for both skull-based lesions as well as intraaxial lesions. This is a case of a cavernous malformation that was involving the superior aspect of the third nerve and the ventral midbrain. I had to expose some of the upper clivus here as well as the tuberculum, again using the Doppler ultrasound to open the cavernous sinus, packing both sides of the cavernous sinus, dividing the inferior hypophyseal arteries, the transcavernous pituitary transposition, again, that Dr. Fernandez Miranda has popularized and introduced. We're doing this on both sides. Again, this lesion is mostly right-sided, removing both anteroclinoid process, and finally dividing the superior intercavernous sinus and making our way back to the interpedocular cistern, making sure that we're not crossing the interdural course of 6. And finally, dividing Little-Morcos membrane. Here is the cavernous malformation. This is the third nerve, compressed and pushed inferiorly. This is the posterior communicating artery meeting the P1 segment to become P2 of the PCA, and the SCA is right under it. An ICA run, again, confirmed that this was not an aneurysm, although we had obtained an angiogram before, and eventually make it in the cavernous malformation, remove the solid components which were in the medial side, and finally the reconstruction. Now, the patient did well. Initially, his third nerve only improved to the point where he could open his eye, but did not improve completely. But he did develop DI in the short term, which required DDAVP. Eventually, he did not require a DDAVP, although he did have some polyuria, which he was compensating for. This was likely because of the posterior gland manipulation. From a series of 20 patients with bilateral interdural pituitary transpositions, there were 2 patients of transient DI and 2 patients that experienced permanent DI. The inferior hypophyseals are thought to provide some blood flow to the posterior gland, although this is mostly thought to be in animals as opposed to humans. This derangement is likely from posterior gland manipulation. This is a patient that I met up when I was on vascular call, which we thought initially she had a benign perimesencephalic hemorrhage. This was a hemorrhagic mass in the interpedocular cistern that turned out to be a pilomyxoid hypothalamic astrocytoma that had bled. It's kind of a similar approach, so I'm not going to spend too much time on it. In doing this approach, and after the transposition on one side, we eventually breached the third ventricle. We had a wide view. This is the basilar tip, and tumor that was nestled in between the PCA and the SCA. These are the third nerves that come in place, but you can see the third ventricle is wide open at the top. So we had used almost everything. She was also kind of a more of a heavyweight young lady. So we had used both fasciolata, fat, a lumbar drain, and she did well. We had kept the lumbar drain for 3 days, and she left the hospital. But 3 weeks after she was discharged, she presented again with a leak, and we had to take her back in an urgent fashion. And essentially, there was a small area at around 11 o'clock of the flap. There was a little bit of mucosa. So as I said, like if small mistakes will come back and bite you. There's kind of an unusual complication. It's a patient that was struggled in the beginning. He presented with vision loss and had this lesion. It wasn't completely suppressing a flare, and it was splitting the gland in two. We discussed it at a skull-based conference, and we initially thought that this was a Rathke's cleft cyst. So the decision making was between an arachnoid cyst and the Rathke's cleft cyst. So thinking that it was a Rathke's, we went to do an infracellular approach. Here is us doing the infracellular approach, but obviously opening up, we realized that this was an arachnoid cyst. I would not have done an endonasal approach if I had known that this was an arachnoid cyst, but we had to kind of save it. So we raised the flap, did a supracellular approach, and you all know the anatomy here, but fenestrated this cyst in the pericellular cisterns in the posterior fossa laterally and repaired it. Given the double opening, I had placed some fat underneath and to buttress the clivus, and we used also a lumbar drain. The patient's vision improved, and he did well initially. He had an MRI before he left the hospital, which looked good overall. But then a few weeks later, he kept calling the office saying that he was not feeling well, and he didn't provide any lateralizing signs. Eventually, he came to clinic, and we got an MRI, and he had gotten a very large subdural hematoma, which I had to take him back to the operating room and evacuate. And this was in all likelihood, we had checked him for a leak. Dr. Eric Wong had scoped him several times. There was no evidence of a leak. So this is in all likelihood a result of a occult leak from the lumbar drain combination with minor trauma. In the prospective series and the randomized trial of lumbar drains, we actually don't have this this complication, but this is a very well-known complication of having a lumbar drain with wide cisterns and an empty brain. And this one last case, this was a 75-year-old nurse that had lost vision for several years and had this anterocranial-based meningioma with, again, significant invasion of the inferior medial canals, significant hyperostosis of the clinoids. So I had taken to the operating room initially with thinking that if we do nothing more than decompress her optic canals, that would have been achieving the goals of surgery, which was just to try and improve her vision. We went ahead to do our usual exposure, expose the optic canals on each side. Specifically in this patient, because of how hyperostotic the clinoids were, you could actually drill all the way laterally into the anterior clinoids above the optic nerves. When we finally opened into the tumor, it was actually a quite soft tumor, quite suckable. So although I went in thinking that would just decompress the optic nerves, we went in to remove essentially the majority of the tumor. This was the final view. Again, this was a 75-year-old lady. She was ambulating with a walker at baseline. Her vision did improve, not significantly, but it did improve to the point where she could actually start reading even before she left the hospital. But the stress of this surgery in a 75-year-old lady caused her to have SIADH, and this turned out to be quite refractory. She never had DI. She never went into triphasic. response. You only had SIADH. She was discharged. We kept her in the nearby rehab facility just to keep an eye on her. But the day that she was going to be discharged from the hospital, from the rehab facility rather, they called us that she actually had, she was not moving her left side. And we got an emergency CT scan. She had an intraparenchymal hemorrhage, and an MRI showed that she had thrombosed both her sagittal and her transverse sinuses. This was a new finding, as she had not this finding when she had this MRI as an inpatient. So she also was found to have downtrending platelets and a positive heparin-induced thrombocytopenia panel. So the combination of SIADH, the dehydration with the heparin-induced thrombocytopenia causes complication to happen. And she went for a thrombectomy, and she was maintained afterwards on blood thinners. And she did overall okay. However, she's still quite weak, especially in the left lower extremity on follow-up. So these are just some examples. I'm sure there are many other ways that things can go wrong in endoscopic skull-based surgery. Again, skull-based surgery, the complication rates are comparable with skull-based surgery and not just pituitary surgery. And obviously, appropriate preparation and anticipation of complications can both decrease the incidence as well as the severity. And with increased experience, as some of my famous mentors have said, with increased experience, the variability decreases. Thank you again for the opportunity to share some of these cases, and I'll welcome any questions if there are any.
Thanks, George. Great selection of tough cases. Get you going on a nice early career here. You're at the right place for this kind of thing. Wonderful, wonderful work. Anybody has any comments?
I have a question. When you all do the optic canal decompression, we don't typically go as far out as you guys, because or if you take tuberculum meningioma, in most cases, the amount of optic canal invasion is just a few millimeters.
Right.
And so I wonder if you decompress the entire canal as far as you can go, do you potentially increase the risk of having essentially optic nerves hanging in the breeze? I mean, I know the dura is intact, but you know, when you put your flap in and you're packing, I mean, we do Maricel, but does it expose more of, you know, the optic nerves to compressive events that you might not otherwise have if you leave a shelf of bone on them and not going as far as you need to, but still you have adequate exposure to take the tumor out of the canal in most cases?
Right, that's a great point, and obviously the right amount is enough, and knowing exactly where to stop certainly would decrease this complication. I think by training, having as much exposure as possible in order to have the best control during the resection stage of the surgery, and sort of thinking about the reconstruction at a later point, it's been mostly kind of the mantra. But your point is spot on, and it definitely increases somewhat the complication. This is a rare complication, I would say.
Sure.
This was a result of possibly dehydrating a lot of the gel foam as well as tight packing, and the combination of the two amounted to this. So it's an unusual thing. Usually when you have to go back, it's because of a clot or something like that. But there was an unusual way of doing this.
Okay, thanks. So now we've heard the 4 speakers talk about different complications. Now Andrew is going to bring it home and tell us how to conquer all complications of endonasal endoscopic surgery. Or is that feasible? Andrew, you've got the stage.
I appreciate that. Can you see my slides?
Yes.
Perfect. Well, I mean, obviously, as surgeons, we know that if you cut, you cry. So it's not an attainable goal. So what I thought I'd do is kind of rename the talk a little bit about, call it slow and steady, how to improve quality in your pituitary program. What I thought I'd do is just try to, tie together some of the themes that have been discussed and how to operationalize some of these tips and techniques for your program. There are obviously many people to thank whose work has contributed to this: colleagues, friends, mentors, residents, fellows who have contributed to the work and improving the quality in the pituitary surgery that we perform here. So, the objectives of my talk are the following: try to indicate some tips to how to improve patient outcomes, how to decrease the variability in those outcomes so the outcomes are more predictable, improve financial performance of your hospital, and ultimately improve patient satisfaction. So this isn't a talk about surgical techniques. It's more of a talk about processes and systems and protocols and building teams. In my first couple of years in practice, I was really horrified by the rate of unplanned readmissions to the hospital after elective pituitary surgery. At our shop, it was bordering on 10%. And it seemed to me for an elective procedure that's primarily extracranial, that was a really high rate. And that was a rate that had been observed by others too. So the unplanned readmission rate was high, roughly on the order of 10%. So we kind of took that as a challenge to figure out how to improve the quality of the program we're offering. There are a number of paradigms that you can look to for guidance for how to improve your quality. The most well-known is this plan, do, check, act cycle, the model for quality improvement. More recently, the ERAS Society has formed, and that's looking specifically at different aspects of patient care, particularly with respect to colorectal surgery, and some elements that you can apply to your program. And those have been shifted to help with spine surgery. So there are some interesting elements that you can include. So let me just share with you some tips about what we've done. And these tips have really been drawn from many of the people who are speaking today. So let me just share with you that experience. The goal we set out, our team set out at the beginning of this process, was to discharge most elective pituitary patients the day after surgery, and without compromising patient safety and without increasing readmission rates. So that was the expectation, that was the goal that we set. So when it was safe to discharge as many people as possible the day after surgery. The program elements are numerous, but they include the list here on this tile. They include having a physician champion or champions who are really invested in maintaining the team and building the team. Patient and caregiver education is critical as well, and I'll share a few slides on that. Getting buy-in from your various stakeholders, coordinating the program, tracking your outcomes, constantly audit them, refining your protocols, and then having an outcomes research program where the outcomes from that research feed directly back into your clinical protocols. The first step, after setting your goal, is to really map out the whole pituitary surgery care process. So what does a surgical epoch look like, from pre-op, post-op, as well as intra-op, and the role of caregivers and family members in that process. So we kind of mapped it all out and tried to work on each of these elements in a stepwise fashion. There are a number of techniques I think that you can employ in your program. The first is patient education, and educating the patient really empowers them through all their phases of care. It helps decrease their anxiety. I think it reduces the number of phone calls to your office and ER visits. So the toolkit is pretty broad. You can develop a patient handbook. There are some patients that really enjoy surgical videos. There are some patients who feel like they've already met you. They've watched your surgical videos. It gives them a lot of comfort. There are other patients who don't take to the videos at all, but it's a helpful technique for certain patients. Providers also perform that education at multiple points along the way. And I can't overemphasize how important it is for the providers to really have the same message and the same script. Because patients will often seize on differences in the message from different providers. So it's important to kind of synchronize your messages about length of stay and postoperative care and expectations. Here's our patient handbook. Maggie Boberwitz put this together. It discussed sort of frequently asked questions and expectations, potential complications. And, patients find this very useful. They'll bring it with them to the hospital, and even post-operatively, I'll see them jotting notes as we're talking during my, post-op rounding. So it's been a very helpful technique. The other important element, of course, is teamwork. And the setup of your pituitary center has been pretty well described by others. This is Dr. Kelly's article from 2012. There's been an update recently from the European group. But the point is that we have to synchronize all these different elements of the team that contribute to successful pituitary surgery. The task is actually pretty daunting. And what I mean by that is this is a map here of all of the sites of service that pituitary surgery patients experience in our medical center. So this is a map of our medical center. These patients are going to radiology, they're going to the lab, the pre-op area. All of these different sites of service need to be coordinated to really help improve your patient experience. And so it takes an incredible amount of teamwork and energy to pull all this together, particularly with a nurse navigator. So to reinforce these principles, we have monthly team meetings. We have a monthly tumor board to coordinate care. We try to coordinate our endocrinology and neurosurgery clinics to at least be on the same day so that it's easier for patients. And I think the role of the physician champion in this process is to try to keep the team together. So as a manager, you realize that your team is constantly trying to fragment, and it's because people come, people go, people take other jobs, some people are out sick, some people aren't performing. So as a leader of your program, you're constantly putting energy into the system to keep the team together and keep it aligned. One of the things we did to try to build camaraderie was we had a very kind of informal tagline contest. So we kind of had team members through a fun process just come up with a quick tagline about what the pituitary center means to you, like what's the essence of the center. And so we did that. That was a lot of fun. We had some great ideas, but it was really just a way to kind of pull the team together and figure out the essence of us and who we wanted to be. The other critical component to a quality program is having standardized care pathways that are really hardwired into your EMR. And when it's possible, you try to draw on evidence basis. If there's no evidence for a particular item, draw on expert opinion. And I've drawn on the expertise of Dr. Kelly and Dr. Laws and Dr. Snyderman, in particular to help build our standardized care pathways for these patients, because it avoids you having to rely on your memory, and it avoids overconfidence bias, which is exists in spades in neurosurgeons. So it's been well proven that standardized protocols help patients. So what I thought I'd do is just kind of talk briefly about a couple of the things that we've done at each phase of the surgical experience. The first is the preoperative piece, and make sure we have a standardized laboratory evaluation for all these patients. Make sure you check prolactin level, so you aren't operating on a patient with a prolactinoma that you didn't realize you're operating on. This is the first part where you're really focusing on patient education and setting expectations for their hospital experience. In surgery, the surgical pause, I think, is critical. And then let me just talk a little bit about some of the care pathway items. We've drawn heavily on the experience of other centers. This is Dr. Law's paper on the surgical checklist that he mentioned. So take this checklist. Dr. Kelly also mentioned his carotid injury checklist. These things are important, I think, to help keep the team together. And so what we've done is just modify it for our purposes. So we have our own surgical pause. And the critical elements before surgery are to assess the carotid injury risk, plan your dural closure, assess the sleep apnea risk, and then steroid management. I think it's helpful to discuss steroid management ahead of time. It's not uncommon that the anesthesiologists try to sneak in that dose of dexamethasone preoperatively, which if you're going to measure postoperative cortisol levels, that can really impact your results. So it helps basically turn a team that looks like this, where everybody's looking on their smartphones, not really paying attention, not coordinated, to turn into a team that looks like this, a high-performing team that's working together for the good of the patient. There's a lot known now about the predictors of length of stay in the hospital for your patients. There's been quite a bit of research published. So those risk factors are known. So you can mitigate a lot of those things, or some of those things, and build them into your quality protocols. For example, pain management. The key elements of our postoperative protocol include glucocorticoid sparing. So our patients who we think are who do not have adrenal insufficiency preoperatively, we don't replace them with steroids. Instead we measure their cortisol levels post-op and then replace them as needed. We have a multimodal pain control pathway, remove the Foley catheter, get these patients walking as soon as possible, manage their sodium, and then also a lot of patient counseling occurs while they're in the hospital through the nursing team, our advanced practice providers, and the physician team. Multimodal pain management, in my experience, has been quite helpful with our patients. And the theory is that try to control pain using medications that work by different pathways because their effects are additive or synergistic. And so that means, non-steroidal anti-inflammatories, Tylenol medication, trying to limit narcotics. And so, we studied this a few years ago in a randomized way, and we found that if you use a multimodal pain control pathway that includes non-steroidal anti-inflammatories and Tylenol, that you can significantly decrease pain scores compared to the narcotic pathway. So this is kind of information you can apply to your pain management strategies to really improve patient experience. And then finally, after surgery, I mentioned to you that the problem I foresaw during my first couple of years of practice was the high readmission rate. And so we went back to the basics and just looked at what our causes of readmission are. And Dr. Laws mentioned this. There are also some other papers that have been published too. This is the one on the right is the Mayfield group. Hyponatremia is a very common cause of readmission from SIDH because of tickling the posterior gland during surgery. So once you kind of understand the common causes of readmission, you can design your protocols around limiting those. Our discharge process is pretty high touch. So there's lots of education while the patients are pre-op, post-op, while they're in the hospital. Those patients get a phone call from a nurse practitioner the day after discharge. They have a standard set of questions that they ask that are focused on the most common complications like adrenal insufficiency and hyponatremia, bowel care, all those things that you want to try to prevent with additional education after they're discharged. And then at 1 week after surgery, that's when they come back and see endocrinology. They see me, they see the otolaryngology team. And the reason for picking that time point is because that's when patients tend to bounce back, is like within the first 7 to 10 days. So that's when we have our clinic visits. We coordinate them so that it limits readmission. That's when we check their post-op sodium levels and their cortisol levels. So all that's part of the discharge process. I mentioned to you, and Dr. Laws mentioned it in his talk as well, that delayed hyponatremia is one of the most common causes of readmission. So based on his work and 2 other papers, this is another paper I highlighted here is the Colorado group, that putting patients on prophylactic fluid restriction dramatically reduces the incidence of readmission for delayed hyponatremia. And then kind of the final technique that we utilize is building a clinical trials program around patient outcomes and using those results to feed into our standardized pathways. So just briefly, before I conclude, I wanted to share with you our results to show you the impact of this iterative quality improvement cycle. Within patient outcomes, this is a slide from Michael Porter, who is, as you know, is the healthcare strategy guru, spends a lot of time on business strategy as well. But he's defined different levels of patient outcomes, tier 1, 2, and 3. Tier 1 are the most important outcomes, of course. Those are the survival and disease remission and quality of life of the patient. That's what you really strive for. A kind of ongoing quality improvement program where it requires frequent audits. But the tier 2 outcomes, which are, I think in the context of pituitary surgery, things like length of stay and unplanned hospital readmissions, are easy to measure. They're understood by hospital administrators and payers. So they're just, I think, good metrics to that can serve as surrogate endpoints for quality, understanding that they're not the most important things to patients, but they are surrogate endpoints. So we've looked over the last 5 years at our experience, and over the last 5 years, there's been really no difference in terms of patient complexity or payer mix or tumor type. So they're roughly equivalent patients throughout the five years. This graph is a whisker plot showing you the length of stay of patients each year. This is elective. These are elective patients only, so elective transnodal pituitary patients. That you'll notice that over time, the length of stay has declined from 2015 to 2019, and the median length of stay went from 2 nights down to one midnight over that time period. As this quality improvement program, continues to grind on and identify areas to improve. The other point I wanted to bring up is, not only has the length of stay decreased, but so has the variability in that. Variability in outcomes is really an essential business metric because, whether you make semiconductors or you manufacture black yoga pants, you need to have high quality that's dependable, that your customers can rely on. So not only did the median length of stay, mean length of stay decrease, so did the variability in length of stay, and that's illustrated here in this graph where on this whisker plot, the interquartile range are those blue boxes. So that's a range. That's a crude measure of variability. That over time the variability has declined as well. You can also measure variability by standard deviation. That's another measure. And if you plot the standard deviation, the magnitude of the standard deviation of length of stay, the standard deviation is also decreased over time. So variability is improving. During that time period, readmission rates have improved. So we were very high, between 8 and 10% in the early years of our program. And then over time, the 30-day readmission rate has declined as we've implemented various quality improvement measures. So we were able to discharge patients from the hospital sooner without sacrificing unplanned readmissions. And this is a slide that the hospital likes, which is the financial performance of the hospital, that over that period of time, the contribution margin has improved. Contribution margin is the amount of money per case that's left over to cover the fixed costs of the hospital. And hospitals have very high fixed costs, and contribution margin kind of helps you measure that. And the profit per surgery on average has increased over time too. And I think this is most likely related to the shorter length of stay. So then let me conclude here by just advocating that a continuous quality improvement program does yield better outcomes and subsequently better financial performance for your hospital. The key elements, I think, for the program to take home are that it's important to have clearly articulated goals, particularly set by a physician champion, align teams, lots of education, track your outcomes, and standardize your care pathways. Obviously, there's more work to be done. The outcomes I reported to you are not the outcomes that are most important to patients. So a focus on long-term outcomes, I think, is what follows this. The other limitation, I think, of this work is, we're making changes over time in often overlapping fashion. It's very difficult to really parse out, what interventions really sort of synergistic. But anyway, I think it ultimately is to improvement. Here's my email, my contact information. I love talking to people about their ideas and what they do at their shop, so we can learn and I can share with you. So feel free to reach out if you have any thoughts or questions about about what you do. So again, thanks very much.
Thanks, Andrew, for this obviously very important line of work that's often neglected, and that's you clearly shown that. As you said, focusing on a problem can really change the whole, patient experience, and all the points you've made are very welcome. I don't know if, can I invite Carolina or Mike, Ivan, my partners? I don't know if they have any comments or any conversation with the panelists.
Actually, I had a question for you, Dr. Little. All the talks were really fantastic. And I think, the quality improvement projects, not only is it's what's best for patients. I agree with you. Hospitals are very interested in this. And a lot of that is financially driven, of course, but the patient outcome coming first. In an era where you have a lot of closed ICUs and you have, a lot of the ICU management happening by the critical care attendings, how do you sort of manage somebody who does go into postoperative DI? I feel like we as neurosurgeons, especially if we're in the operating room, we see that the gland's intact and we think this is going to be something transient. I think we're able to tolerate, as long as the patient's thirst mechanism is intact and the sodium is staying relatively stable, we tolerate high urine outputs much more so than what I've seen in my sort of critical care colleagues or the endocrine colleagues. So how do you sort of manage that? Or is that, do you guys have a set protocol for that in terms of at which point to give DDAVP? Because I've seen that come up a few times where they want to give and you feel really sort of that it's not necessary. And sometimes it sort of mixes the pictures because they're just mobilizing initially and then, they'll go on a DDAVP regimen and they don't really need it. It sort of delays their discharge.
Yeah, that's great. And I think that, highlights the challenges of quality improvement programs at different shops, because each institution has different protocols and policies and politics. I guess my strategy with these cases are, I try to engage the team as partners, so the critical care docs and the endocrinologists as partners. My impression is that as the neurosurgeons who perform these cases, we see a lot more DI than the endocrinologists do or the critical care docs do. So they often will look to me for some guidance. So at least at our shop, there's not really much of a competition, or there's not really a power struggle at all. It's very much we partner together to manage these patients. The other good thing is, postoperative DI isn't very common. We see much more SIADH than we see DI these days because of the gland sparing techniques that the endoscopic approach allows.
Great, thank you. And one thing for Dr. Snyderman, I know, I trained at NYU, and that's where I did my fellowship as well. And we were actually, just as I was leaving, we started up a project where we try to discontinue postoperative antibiotics in the endoscopic cases. I know the concern is toxic shock syndrome, but how often do you really see that? And we looked at about 70 people where we prospectively stopped antibiotics, and we did not notice a rate of increase in sort of in postoperative infections or meningitis, even in patients with CSF leak or, the presence of a lumbar drain. What are your thoughts on that, on discontinuing postoperative antibiotics?
Well, the latest literature shows that you don't need postoperative antibiotics if you don't have packing in the nose. You know, a straightforward pituitary surgery where there is no leak and no substantial packing, you don't need antibiotics, and we don't give them. However, if we certainly, if there's packing, Maricel tampons or a Foley balloon catheter, we feel it's very important to give oral antibiotics as long as the packing is in place. Although I can't say that I've seen any episodes of toxic shock. I have seen patients develop severe cellulitis from a lapse in antibiotic coverage. And it can happen quite rapidly. And just having a very infected environment with the tampons in the nose that close to reconstruction has to increase your risk of getting meningitis. So I don't recommend it. I think it's absolutely necessary to cover patients in that situation. And then there's an in-between category of patients, those who have absorbable packing like the nasopore. And our protocol has been to keep them on oral antibiotics for 4 to 5 days, just because it is still a foreign body until it starts to dissolve and is a potential site for infection. So we think that's been well tolerated. We've had no problems using that protocol.
We have a question from the audience member here. Do you put all your patients in prophylactic fluid restriction or under selected criteria? How is the patient compliance and success rate with, I guess, prophylactic fluid restriction? To any of the panelists.
So I can comment on that. We scare the hell out of the patients. And we tell them that if they drink too much fluid, they're going to get a convulsion or even die. And of course, I believe that. And therefore, we send our patients home on with a 1 liter pitcher, and they are restricted to 1 liter a day. And we see them a week after their operation and measure the sodium and turn them loose if they have dropped or have got a normal sodium level. That's worked fine. We haven't had a single readmission since we started that protocol, which was about 2.5 years ago.
Yeah.
So it worked. I mean, it means that the patients have to believe the doctor, you know, or the nurse. And it was the nurse, or my nurse practitioner figured the whole thing out. But it was a nurse, you know, to tell them that if you drink too much, you dilute your blood, sodium goes down, and it's very bad for you.
Right.
Hey, Ed, may I ask you if you could think back at your earlier career of all the very important lessons you shared with us, which is a lesson you hope today you had learned much earlier in your career? You know what I'm saying? Looking back, what lesson took you the longest to, you know what I mean, to learn?
Gee, that's a very good question. I think it's been a gradual improvement with technique and knowledge. And I think image guidance played a major role for us. And because when you're operating on the basis of visualized anatomy through a microscope with blood everywhere, it's completely different from what we do now with the endoscope, bloodless environment, and image guidance to check to be absolutely sure where the carotids are and where the tuberculum is and where the clival lesion might be. We've come a long way, and it's an incremental thing, and it has been a joy to see it improve progressively. And, you know, the people who are talking today are pioneers in taking it even more steps further forward. But it's been a wonderful way to deal with the common problem and excellent results.
Great.
I had a question for Dr. Laws, if possible. Dr. Laws, I think you were one of the, if not the first person to actually try to quantify and characterize the notion of headaches associated with pituitary disease. And you published a paper and detailing, and which was a beautiful paper, the character of headaches, etc. But on a day-to-day basis, in simple words for us, how do you deal with with headache and a pituitary patient that comes in and has been followed for some time and then complains of headaches and comes wants their pituitary out, although they don't have any chiasmal compression on any
You know, that
hard evidence for
every week we have these referrals from the headache doctors who are dumping the patients on us because a radiologist may say, well, there may be a microadenoma in the pituitary, or the pituitary is too large. I explain to them that if you have a lesion in the pituitary that's causing a headache, it usually causes endocrine abnormalities that we can detect. And if we can't detect them, and the only problem is headache, it's not a case that I would want to operate on. Occasionally, we'll give them a trial of steroids, you know, the crazy headache people, right? And give them a Z-Pack and see if it helps their headache some. And then I think a little more kindly about them. But most of the time, we just send them back to the headache doctors.
Excellent, thank you. I also had one question for Dr. Little. Thank you again for a wonderful presentation. We just started here as well through like an electronic dashboard to try and capture some of that information. Indeed, even the short period of time, having real time information about some of the outcomes is just it's so useful. But I guess my question is, many of the limitations of having this feedback and this quality control are the logistics of how to acquire that information, and it takes manpower and infrastructure and an investment to do that. And I was wondering, how do you do it? How did you structure it to start doing it, to have such accurate data on so many parameters?
Yeah, well, you know, I didn't give a shout out. I shouldn't have given a shout out to Dr. Saris, who helped put that data together for me recently. We don't have a great system for real-time data, and as you know, the data you get even in real time is pretty dirty,
Right.
and may not be that applicable. So it just, you know, it takes a lot of effort. A lot of uncompensated time devoted to just trying to understand your data. Our data is not very clean. It just requires quite a bit. And, as Dr. Saris can attend to, if you want to look just at pituitary adenomas, for example, and you get it from the hospital, they'll have some craniopharyngiomas and some meningiomas in there, and you got to just kind of clean all that stuff out. But it's a challenge, no question about it.
Any other comments?
I thought Andrew's talk, that was excellent and really interesting data. We're trying to do some of the same thing. And I think what you said, and I think what Ed alluded to, is this idea of preparing the patient and telling them what to expect, and telling them that, you're probably going to go home the day after surgery. I think that's a really good thing. And then this follow-up and the constant reminders and having a script, I think, is really critical for having this sort of smooth post-operative course and avoiding readmissions and lots of phone calls and that kind of thing. The hyponatremia stuff is really, really important. I think, Ed, you finally solved it with the 1 liter jug.
Right.
And the admonition about seizures and death.
Right.
It really works. And I think that it is an operation when it's done like this for most straightforward adenomas. The patient these days should go home the day after surgery. And I think that's we're seeing that all over the place. I think it's really a nice trend. So,
Yeah, you know what?
Yeah,
Let me
agreed.
make an old-fashioned comment about this. One of the joys of being a doctor is taking care of patients and getting to know them, and having the satisfaction of seeing how they are after you've done an operation. As it is now, our residents haven't seen the patient beforehand. They've really never talked to them except to do a consent. They never see them afterwards except on rounds for 2 minutes. And if you send them home the next day, they never really see how they are. And they don't see them in follow-up clinic. We don't bother them with that. What does it do? What does it do to burnout?
Well, that may be true for the residents. In our fellows, they see them pre-op and post-op, and they see them in clinic.
We can't do that with COVID now. We cannot do that. It's impossible. We're doing everything by Zoom, and the residents haven't got time to sit in a Zoom conference.
But what about pre or post-COVID? I mean, when we're going to be on the other side of COVID, hopefully.
I didn't understand what you said.
What I said was, beyond the pandemic, when, you know, in your normal setting, do your residents get much patient exposure? I mean,
almost none. In our regular residency before this illness occurred, the residents almost never saw patients in clinic before or after surgery.
Ooh. Yeah, that's not.
We have a lot of residents, 3 a year, and we don't have enough person power or desire on their part to do it. I never wanted to be in clinic when I was a resident.
You didn't turn out too badly, Ed, I guess.
Right.
I have to say, I didn't.
Yeah, but I didn't send my patients home without seeing how they recovered.
I feel like one of the, obviously the operating room was the most exciting part of fellowship, but one of the most beneficial parts of fellowship was actually going to clinic and having that experience. And now as a junior attending, I feel like that was tremendously helpful.
Absolutely. That's how they do it. That's how they get that kind of information with a fellowship.
Well, ladies and gentlemen, it's 7:23 p.m. Miami time. I think it's time to let you go, and I'd like to thank the audience that stuck with us. This was fantastic. Of course, it's been recorded, and invite your trainees, your colleagues to come and watch this wonderful session and learn all the little details that get missed on a first pass. So thank you to all. Have a great evening. Bye-bye.
Thanks, Jacques.
Thank you.
Jack.
Bye-bye.
Thanks for doing this.
Everyone.
Thank you.
Bye, everybody.